Good evening, everyone, and welcome to this highlight symposium from TOGA. We'll be covering in this session highlights from three recent major conferences: the World Conference on Lung Cancer, ESMO and ASTRO, all held in rapid succession. My name is Ben Solomon. I'm a medical oncologist from the Peter MacCallum Cancer Centre in Melbourne, and it's my real privilege and pleasure to be joined by three of my colleagues, Professor Ken O'Byrne, Dr. Lucy Cork, and Dr. Fiona Heggie-Johnson, to cover highlights of these three conferences. And as is important for us to do, it's important to acknowledge the traditional custodians of the land on which we live and work, and we pay our respects to the elders past, present and emerging. And we also extend that respect to all Aboriginal people, including people who may be participating in this meeting. It's also important to thank our sponsors, without whom we wouldn't be able to do this. And in particular, we'd like to thank Boehringer Ingelheim, as well as AstraZeneca and Pfizer, for sponsoring this event. So, sorry, just a little bit about TOGA. TOGA, we've got our vision and mission statement here. Our vision is to eliminate thoracic cancers as source of death, disability, and suffering. And our mission is to prevent, treat, and cure thoracic cancers through research, clinical trials, education, and advocacy. And we really do encourage all of you to join TOGA and participate in our various activities, including our clinical trials. And membership really is open to anyone with an interest in thoracic malignancies. And you can access a link through this QR code, or really easily through the through the website to find out more about TOGA activities and to join. And I encourage you to have a look at the website. But this evening we've got a really excellent program with three speakers. And I also just wanted to highlight that immediately following this session, we've got a microsatellite symposium about HER2, which I really encourage you to stay on for. We'll have, so the format of the evening will be that we have presentations from each of our presenters, followed by a Q&A session. So please feel free to put your questions in the chat, and we'll try to address as many of them as we can. So without further ado, we'll move on to our first presenter, who's Professor Ken O'Byrne, well known to all of you. Ken's a medical oncologist at the Princess Alexandra Hospital, and also a translational researcher in lung cancer at the Translational Research Institute at the Queensland University of Technology. Ken?
Thank you very much, Ben. It's my pleasure to be here this evening, and I'm going to do a whistle-stop tour through some of the findings of the recent meetings. Very exciting meetings, by the way. So these are my disclosures. So I'm going to start off with small cell and neuroendocrine lung cancer immunotherapy. There were a number of studies presented at the meeting. This is a study of a novel agent, BMS 986012. It's an antifucosyl monocyclic ganglioside 1 monoclonal antibody with carboplatin and etoposide and nivolumab as first-line therapy in extensive disease. And there was a randomization of this drug with immunotherapy and chemotherapy versus nivolumab and chemotherapy. This agent has a number of effects that induce immune responses. They include the activation of phagocytosis, antibody-dependent cell-mediated cytotoxicity, complement-dependent cytotoxicity, and of course, nivolumab activates the immune response by blocking PD-1. And just I'm going to show the overall survival curve, and this showed an improvement a median survival of 4 months, with the overall survival seen both in patients with CNS disease and also in patients without brain metastases. And so this drug will now move forward into a phase 3 trial. And the interesting thing about the drug is it's incredibly well tolerated, apart from one toxicity, which is pruritus. This usually is short-lived. It occurs for approximately a month and fades away over time, and is managed with antihistamines and topical agents as required. The next drug is tarlatamab, a very interesting bispecific T-cell engager with a PD-L1 inhibitor in first-line maintenance chemoimmune therapy for extensive stage small cell. Patients had the platinum etoposide and PD-L1 inhibitor 4 to 6 cycles, and then depending on whether they were on atezo or durvalumab, and they were followed up with maintenance therapy with tarlatamab. Now, tarlatamab, as you know, is a bispecific antibody. It's got a CD3 binding domain. You can see it here binds to the T cell, which can lead to T cell expansion. It also binds to DL3 on the small cell and also other neuroendocrine tumors. And then this activates the T cell to kill the small cell in a simple way, and leads to tumor responses in a proportion of patients. And you can see here the data. The PFS was 5.6 and 5.3 months in both the atezolizumab and durva arms, and the total tarlatamab IO was 5.6 months. What's really impressive is the overall survival, which at 9 months is 86 and 91%, or 88% of patients overall. And this is kind of really encouraging data, and augurs well for the future for BiTEs in this particular situation. Likewise, there was always a concern about the side effects, both the ICANS CNS side effects and the CRS cytokine release syndrome. And again, relatively well tolerated. It was grade 1 when it occurred in the majority of patients, and grade 2 in a subset, and occasional grade 3. So we have, as you know, all centres are developing mechanisms for dealing with this. You can see here's a CRS with durvalumab, no difference really between the two arms. Now, this is a drug. I'm just going to flick forward to what the drug actually is. A phase 1 trial of a further DL3 CD3 T-cell engager, and it developed by Boehringer Ingelheim. And these are the data. Overall, you can see the patients here. There was a mixture of patients with neuroendocrine tumors and small cell all lung cancer tumors. And particular interest was paid here to the large cell neuroendocrine population. And a subset analysis showed that of 10 patients, 7 had partial responses, and you can see the responses here. So this might represent another approach to looking after large cell neuroendocrine disease, combining tarlatamab with other IO therapies, PD1, PD-L1 inhibitors, but also with chemotherapy. And then we look at the toxicities of this particular drug, you can see that they're pretty much what you would expect. Overall, reasonably well tolerated, but there was a grade 3 level in 24% of patients, and some of that was a lymphocyte count decrease. So not a particularly worrying decrease, but it looks like an exciting drug. Now, moving on to antibody drug conjugates, what we see is that there's a whole range of these drugs coming out. I mean, literally hundreds being developed at the present time. So what about small cell? Again, we see this in ifinatamab deruxtecan. This was given at 2 dose levels, 8 milligrams per kilogram and 12 milligrams per kilogram. And overall, there was 88 patients in this study, but 70% of them had 3 lines of previous therapy. Or this was the 3rd line therapy. And you can see here that the response rate was certainly very reasonable with the 2 drugs, 26%, and sorry, with the 1 drug, but at 2 dose levels, 26 versus 61%. And so, interesting also responses in the CNS, intracranial response looking very encouraging for these agents. Or for this agent. This is the progression-free survival, slightly better with the higher dose than the lower dose, and the overall survival, again, slightly better with the higher dose and the lower dose. But the lower dose, again, showing activity, and particularly important here is that with the lower dose, really virtually no significant grade 3 toxicities. And you can see it over here with the higher dose, again, a little bit higher, but again, relatively low neutropenia grade 3 level for a drug like deruxtecan. So encouraging data in this particular area. Now, there were 2 TROP2 targeted agents presented. One was this drug, SHRA1921. This was in patients who had more than one line, or at least one line of platinum-based chemotherapy previously, or more than one line of previous treatment. Prior immune checkpoints and topoisomerase 1s were allowed, and any TROP2 expression and good performance status. And again, we saw evidence here of anti-tumor activity, which was encouraging. You can see the PFS 3.8 months, but again, reasonable response rates. Looking at the toxicities, one of the things that stood out for me in this was the stomatitis level. Stomatitis can be a bit of a problem in patients who are receiving TROP2 targeted therapies, and we're seeing this as a class effect, but not with all of the agents. And one of those agents is sacituzumab govitecan, which has been used and reported with the EVOKE trial. Again, equivalent to docetaxel, not superior. But again, when you look through this drug, and this was the same also in the EVOKE trial, really no stomatitis. So kind of interesting differences in the toxicities between agents targeting TROP2, suggesting some differences in delivery or antibody effects, and something that needs to be explored probably in the future. Now we look at datopotamab docetaxel DXd versus docetaxel. Everybody's aware of this trial. This was a randomized phase 3 trial, TROPION-Lung01, and you have 299 patients in one arm, 305 patients in the other. And this was looking at the overall survival, and really no clinically significant difference in overall survival, 12.9 versus 11.8 months. And when you look here at the non-squamous population or the squamous population, there seems to be some benefit in the non-squamous versus the squamous. But it is a subset analysis, and the numbers of patients are relatively small in the squamous cell group. Looking at the groups again, just so you can see here the benefit for overall survival. It appears if it's any in the non-squamous group, you can see with squamous didn't seem to be any particular benefit. But looking at the toxicities, comparing both the docetaxel with the dato-TX, the one that struck out for me was stomatitis was significantly higher compared to docetaxel with the dato-DX. Nausea again a little bit higher as well. And then the more predictable toxicities with neutrophils, neutropenia, etc., seen with docetaxel. So looking at a normalized membrane ratio, however, there may be a marker that predicts benefit for this agent. And this is obviously something we're going to look forward to in the future, using AI to look for biomarkers. And what was interesting here, if you look at the combination score of membrane and cytoplasmic expression, divide membrane by these two, you find in those tumors that have a relatively low level of a low score, which means that there's relatively more expression in the cytoplasm, those patients tend to have a better response. And this is shown here, where you've got the biomarker population doing well. And so I think this is, irrespective of whether you find an oncogene driver, and this is kind of, I think, an interesting result, something exciting for the future. And then to mention the Carmen study, this was a phase 3 trial. Some of people here, I'm sure, were involved in this trial, comparing this drug to docetaxel. And we can see again that there really wasn't any improvement in progression-free or overall survival with this treatment. And these patients, the CCAM patients in the trial, had to be CCAM positive. Again, showing that in this particular setting, second line setting, it's very difficult to beat docetaxel. So it's a bit of a high bar in these particular settings. So conclusion really that with non-squamous non-small cell lung cancer, this agent failed to demonstrate a significant improvement in progression-free survival compared with docetaxel. And then I just want to finish with two other, I think, studies that were kind of interest. One is the bispecific antibodies, and with Mariposa 2 updates. These were given by Sanjay Popat. And it's a second interim analysis of the combination of amivantamab with chemotherapy versus chemotherapy alone, a large trial. And what we see is that the overall survival of the combination is being maintained over time. So at 18 months, it's 50% survival versus 40%. And this is, has a ratio of 0.73. So probably a meaningful 17.7 versus 15.3 months. So it was a meaningful benefit for patients. And you can see no matter what measure you look at in terms of survival, there's an improvement. So to me, I think one of the key aspects here was an analysis of the biomarkers presented by Dr. Bayes et al., Benjamin. And you can see here that in terms of resistance, look at comparing osimertinib to amivantamab, you can see that the MAT amplification was significantly lower with the amivantamab than it was with the osimertinib alone. And then you've got osimertinib versus amivantamab. This was in the Mariposa trial, comparing these first-line amivantamab plus lazertinib versus osimertinib. You can see that with osimertinib again, your secondary EGFR resistance mutations are higher than in the osimertinib, than the combination arm of amivantamab plus lazertinib. So in this situation, resistance mechanisms are different, and you can see that the difference is expressed here with HER2 amplification being up and also alterations in cell cycle. So we're learning about the resistance mechanisms with this combination in the first line setting of amivantamab plus lazertinib versus osimertinib, and this helps to inform what we might do better in the second line setting when resistance occurs. And then one last little one, I thought it was nice just to mention that a novel potential chemotherapeutic agent got mentioned in the meeting, and this was looking at the plinabulin, docetaxel versus docetaxel, and this drug is a polymerization, a tubulin polymerization inhibitor, and it affects angiogenesis. It's an anti-angiogenic. It also it has a pro-immunogenic effect, and is involved in activating the JNK pathway. And you can see here the combination of this drug with docetaxel was compared to placebo and docetaxel. And surprisingly, we had a positive overall survival benefit with a hazard ratio of 0.399. 2-year survival rates were higher and 3-year survival rates were higher, and also an improvement in progression-free survival. So, interesting study to finish with. Maybe chemotherapy in this particular setting is not yet finished. And so the future, what I think in the summary, we have really encouraging data with immune therapy, advanced immune therapy in small cell lung cancer moving forward from the PD-L1 story. It looks like the antibody drug conjugates are certainly going to be encouraging in the small cell setting. It's tough to get over the bar against docetaxel in non-small cell lung cancer. However, we may be developing using AI, a really potent biomarker for TROP2. It needs to be tested in prospective trials. And then, the Mariposa, the amivantamab agent looking encouraging, particularly, and maybe getting with chemotherapy in the second line setting, but also in the first line setting, getting some ideas about how its resistance is different than that from osimertinib alone in that randomized trial for the biomarker studies. So thank you very much for your attention. Very exciting times. The future is bright for small cell, and also I think also for targeted therapies. Thank you.
That's fantastic. Thanks very much, Ken, and very appropriate that you end on a study called the Dublin 3 study. Um, so we'll move on to our next presentation, and our next presenter is Dr. Lucy Cork. Lucy's a medical oncologist who's returned from a fellowship at the Princess Margaret in Toronto to take up her current role as a medical oncologist at the Calvary Mater in Newcastle. So, yeah.
So thank you very much, Ben, and thank you to TOGA for the opportunity to talk tonight. These are my disclosures. One of the abstracts that I'm talking about tonight is called Galaxy. So I have gone a little bit Star Wars themed, and I'm sorry in advance to any of the diehard Star Wars fans if some of these analogies are a little bit of a stretch. But essentially, a long time ago in a galaxy far, far away, the only way that we were able to fight lung cancer or the Death Star was with chemotherapy or these rebel fighters. And while they were pretty good at blowing stuff up, they weren't particularly targeted or sophisticated. And as we've learned more about lung cancer, we've learned that we also need to consider the tumor microenvironment, which can change the course of battle. So we've developed immune therapy drugs and targeted therapy drugs, but unfortunately, whatever we do does develop resistance. But there is new hope. And so these are some of the studies that we are going to fly through this evening, looking at some novel combinations and dosing in immune therapy and some novel agents and targets. So in immune therapy, I describe immune therapy to my patients as a way of breaking down the defense shield around the tumor, like this shield generator. Immune therapy can go in and can try and break that shield down so that the Death Star can be destroyed, but they can lead they can often sort of get stuck or get exhausted. And so there's a desperate search to develop new strategies and new teams. So Harmony 2 is the first study that I'll talk about. This was presented at World Lung by Kai-Sun Zhao. Ivonescimab is a first-in-class PD-1 and VEGF bispecific antibody. It's felt to have cooperative binding activity, so the VEGF and the anti-PD-1 give each other higher affinity to bind to one another and also increase binding of T cells. This was a randomized double-blind phase 3 study of patients with advanced PD-L1 positive non-small cell lung cancer. Patients were randomized to receive ivonescimab 20 milligrams per kilo or pembrolizumab 200 milligrams every 3 weeks up until 24 months. And the primary endpoint was progression-free survival. The patient characteristics were well balanced and fairly typical of this tumor population. 45% had squamous cell cancer, and somewhat surprisingly or bravely for a study using a VEGF inhibitor, they permitted tumors with cavitation and necrosis and even tumors that were encasing larger blood vessels. This is the results from the primary endpoint. The median PFS almost doubled from 5.8 with pembro to 11 months with ivonescimab with a hazard ratio of 0.51. It was significant and very deserving of the applause that it received. And while it might not be a truck, you can definitely fly a Millennium Falcon through these curves. All of the patient subgroups appeared to benefit with ivonescimab compared to pembrolizumab. And in the pre-specified subgroups, ivonescimab demonstrated fairly significant improvement in progression-free survival, regardless of the PD-L1 expression or the histology. In terms of toxicity, there were higher rates of grade 3 and serious AEs with ivonescimab compared to pembrolizumab, but these were largely lab-based changes, so some transaminitis, bilirubin, amylase, and the rates of discontinuation of therapy were low in both groups. There was no significant increase in immune-related toxicity with the ivonescimab. As expected, there were some VEGF toxicities in about 50% of patients, but only 10% of these were grade 3. And interestingly, none of the squamous cell patients had any grade 3 bleeding, and there were no VEGF-related deaths. Quality of life data was included, which was really nice to see, and it does look like both drugs were fairly comparable. So while this data looks really exciting, one of the main criticisms was that pembro monotherapy is available for us with this PD-L1 low population, but it's not usually the preferred treatment of choice. We would usually offer these patients pembro chemo. And so where this would fit in our current therapy remains unclear. The other criticism was that this was an all-Chinese study, and so we're waiting for trials looking at more generalizability. This is obviously a drug that has effect, and they're looking at phase 3 studies in a number of different tumor types. And there was also some data presented at World Lung using the drug in perioperative lung cancer, which looked interesting. So Relativity 104 was presented by Dr. Nicholas Girard at ESMO. We know from melanoma that the combination of Nivo and relatlimab, an anti-LAG3 antibody, is effective and is approved in Australia. But Relativity 104 is the first randomized phase 2 study to look at this combination in first-line treatment of advanced non-small cell lung cancer. Part 1 of the study was looking at safety of various dosing, and to note that the dose that they went forward with the relatlimab was higher than they use in the melanoma setting. So in the part 2, or the second part of the study, patients were randomized to receive the Nivo-Rela combination with 4 cycles of platinum doublet chemotherapy compared to Nivo with the platinum doublet chemotherapy. The primary endpoint was overall response. And in the intention to treat population, in terms of the primary endpoint, overall survival was 51% compared to 43%, but the PFS improvement was not particularly significant, and the overall survival data remains immature. When they looked at the pre-specified patient subgroups, they did see a significant benefit in PFS in the PD-L1 positive population. and also a trend within the non-squamous population. So they combined these two groups in an unplanned analysis, and they did demonstrate a more significant benefit in PFS, 9.8 versus 5.6 months, with a hazard ratio of 0.45 and a doubling in response rates. In terms of toxicity, grade 3-4 treatment-related adverse events occurred in about half of patients in both arms. Rates of discontinuation and rates of death were also similar, and the grade 5 toxicity was mostly related to chemotherapy. So while this looks interesting, I think we do need to wait for the larger phase 3 trials. They're moving this combination forward within that 1 to 49% PD-L1 positive subgroup. The discussant for this trial compared what we have so far with the relativity study against the sort of combined data for previously published studies, and it does look favorable, but we need to wait and see. And it's also being moved into phase 3. So Galaxies, Lung 201, the theme of the talk. This was presented by Dr. David Spiegel at ESMO, and this study looked at belrestotug, which is a novel and potentially more potent TIGIT inhibitor, with or without dostarlimab in patients who had PD-L1 high non-small cell lung cancer in the first-line setting. Patients were randomized to one of several arms, but this analysis was looking at the dostarlimab monotherapy versus in combination with various doses of the belrestotug, and the primary endpoint here was response rate. You can see that there was a significant improvement with all of the combination arms compared to dostarlimab monotherapy, 60 to 65% in the confirmed OR versus about 30% with the dostarlimab. In terms of toxicity, the combination definitely did lead to increased treatment-related and immune-related toxicity, especially in the highest of the belrestotug doses, and they've moved forward in further studies with the 400 milligram dose. Again, the discussant sort of compared this data versus what we know from the other studies that have assessed this population, and the response rates certainly improved, but we don't have any PFS data yet. And we know from previous studies that have looked at TIGIT, so tiragolumab was sort of very favorable looking in the phase 2 Cityscape study in combination with atezolizumab, but the phase 3 data hasn't yet demonstrated any PFS benefit. A final immune therapy study was the Dedication 1 or the NVOLT study, which was comparing low-dose pembrolizumab as monotherapy or in combination to regular standard dose. The primary endpoint was non-inferiority for overall survival, and this was an interim analysis, and they used 10% as the cutoff for stopping the study. This is the 1 year survival data, and you can see in the standard dose, it was close to 58% compared to 55% in the reduced dose. The response rates between the arms were similar, and there was a 2.7% survival difference, which meant that 10% cutoff for ongoing continuation of the study. I guess the significance of this study, if it proves to be positive, is massive for potential healthcare costs, whether or not this data could be extrapolated into the other PD-1, PD-L1 drugs, as we're using more and more immune therapy in different tumor sites and in earlier stages of disease. This could be quite a groundbreaking study. And there are other similar studies being done in the States and in Europe. So moving on to targeted therapies, the non-EGFR ones, because Ken's already talked about Mariposa. ALCOVE-1 was presented by Dr. Alexander Drion. This was a phase 1/2 study of the nuvalent drug NVL-655 in previously treated ALK-positive solid tumors. This is a rationally designed TKI that has potent activity against single but also against compound ALK resistance mutations that are seen more commonly after patients have been treated with lorlatinib. It looks like the brain penetrance is very similar or comparable to lorlatinib, and it's been specifically designed to avoid some of the TRAC inhibition that's associated with a lot of the neurological side effects that we see with LORLA. The patients were heavily pre-treated, with 2/3 of them receiving 3 or more prior lines of treatment. 85% of patients had already had lorlatinib. Over half of them had a secondary ALK mutation, and half of those were compound mutations. So response rate across all patients was 38%. In the patients who had received prior lorlatinib, it was 35%, but higher in those who had compound mutations, 54%. In those patients who had not received lorlatinib, response rates were over 50%. So obviously a very active drug. Interestingly, the responses were also quite durable, around 14 months, but not reached in the phase 2 dose moving forward. And that was seen even in those patients who had previously had lorlatinib and had compound mutations. The safety profile appeared really favorable. Most of the AEs were grade 1 or 2, with transaminases the most common. There was a little bit of TRAC effect with very mild amounts of dysgeusia. This drug has now received FDA breakthrough therapy designation, and there are ongoing studies happening. So the same company that made that drug has also made this drug, NVL-520 or zidesamtinib, and this data was presented by Dr. Benjamin Bess. Similarly to the previous drug, it's been rationally designed to target ROS1 fusions, resistance mutations, to be brain penetrant, and to avoid TRAC toxicity. Again, patients in this study were heavily pre-treated. 70% had received 2 or more prior ROS1 TKIs, including repotrectinib and lorlatinib. Across the entire population, the response rate was 44% in this heavily pre-treated population. It was slightly lower in patients who had received previous repotrectinib, but was 73% in patients who had had crizotinib only as their previous treatment. The safety profile was again really very favorable. The rates of adverse events were very low, particularly when you compare that to what patients experience on our current ROS1 drugs, and there were no adverse events that led to discontinuation. So it's very promising, and ongoing studies are happening. Finally, and very quickly, I just wanted to mention the AMG 193 study, which was presented by Dr. Adrian Sacho, who is one of my mentors over at Princess Margaret. AMG 193 is a PRMT5 inhibitor, and it exploits this vulnerability in tumors that are MTAP deleted. And this occurs in several different tumor types, most commonly found in GBM and mesothelioma, but is found in about 20% of patients with non-small cell lung cancer. So it's a very early phase study, but it did look like there was activity of the drug across an array of solid tumors. The median duration of follow-up at this point was only about 5 months. 5 out of the 17 non-small cell patients had a partial response. And in the other tumor sites, there were about 6 patients who'd had partial response and 6 patients with stable disease, you can see on the top graph, who were continuing on treatment. So obviously has some durability. The safety profile was acceptable. Nausea, vomiting, and fatigue were the 3 most common, but none very severe. So I guess in summary, optimal immune therapy combinations remain a work in progress. While the IO VEGF bispecific ivonescimab appears really promising, we need to wait for global studies and for possibly studies that use a different comparator arm. LAG-3 and TIGIT remain interesting, but we need more data. We desperately need biomarkers to try and help work out which of these patients are going to derive benefit. And it looks like these new rationally designed ALK and ROS1 agents are very active in these heavily pre-treated populations with much better tolerance. So it'll be interesting to see how these get sequenced with our current standard of care, and whether or not, because these are better tolerated drugs, whether we can start to move them forward to an earlier stage. So hopefully together we can eliminate lung cancer.
Very, very nice. Lucy brought home like Elon Musk bringing home the SpaceX booster rocket. Well done. For our final presentation, we've got Fiona Heggie-Johnson, who's a radiation oncologist at the Peter MacCallum Cancer Centre. Fiona's led or leading some really innovative trials, including trials with stereotactic radiotherapy in brain metastases and some really exciting novel imaging studies. And Fiona will be talking to us about some of the radiation highlights from radiotherapy highlights from these meetings. Fiona?
So thank you very much for giving me the opportunity to talk about radiation oncology trials in the most recent meetings. And I'm going to start with limited stage small cell lung cancer and talk about two large randomized studies, LU005, which is presented at ASTRO, and Adriatic, which released additional data at ESMO. These are really exciting studies because radiation oncology treatment in small cell lung cancer has essentially not changed for 30 years. And we have not shifted the needle in terms of survival, with long-term survival for limited stage patients remaining about 30%. And the standard approach of thoracic chemoradiotherapy defined almost 30 years ago now in the Thoracic study in 1999, which showed that giving radiotherapy as accelerated hyperfractionation, which means giving smaller doses of radiotherapy twice per day, works better than giving once daily 2 Gray fractions, and attempts at dose escalation in the CONVERT study with conventional fractionation to 66 Gray had no benefit. So the LU005 and Adriatic studies attempted to apply the lessons that we have learned in extensive stage small cell to limited stage patients. In the extensive stage patients, we know that adding immunotherapy into the mix, whether atezolizumab or durvalumab, seems to improve survival. And both of these very ambitious randomized trials attempted to see if adding immunotherapy to concurrent chemoradiotherapy would have similar benefits. LU005 is a collaborative group study led by NRG. It recruited more than 500 patients in the US, Canada, and Japan. In this study, the atezolizumab started with the second cycle of the chemoradiotherapy. In this study, also, patients were identified and recruited before the radiotherapy commenced. Adriatic is a large randomized study performed in Asia, Europe, and South America, with a high proportion of patients coming from low and middle income countries in those settings. In this particular study, the major difference in terms of the immunotherapy was that the durvalumab started after the thoracic radiotherapy had finished, and patients were screened and recruited after the thoracic radiotherapy was done. Now, the LU005 study, because it's a radiation oncology collaborative group study, has a really impressive RTQA protocol. All centers underwent RTQA, and 97% of plans were compliant, with more than 90% of patients receiving advanced radiotherapy treatment. So it was very disappointing to see at the most recent ASTRO meeting that this is a negative study, negative in every sense, negative in terms of infill failure and in terms of PFS and overall survival. And this is in marked contrast to the Adriatic study, where there is a benefit both in terms of overall survival and progression-free survival. So what are the differences between these trials? It's not very intellectually sound, but if we are to compare them, it seems to be unlikely to be the immunotherapy because both durva and atezo work in extensive stage patients. The Adriatic cohort potentially had more favorable biology, and this is partly because of the way the patients are selected. They are selected at the end of the thoracic radiotherapy, so we know they have stable disease before they began. But in LU005, 8% of patients did not complete concurrent chemoradiotherapy, but were still analyzed by intention to treat. There may be also differences in terms of biology. In patients who have small cell lung cancer, we know that it's not a uniform disease, but there are multiple subtypes. And each of these subtypes has a distinctive immunophenotype and response to immunotherapy. We don't understand how these subtypes are distributed across the world. Similarly, information, including information from my colleague Robbie Samstein, who gave this beautiful discussion at ASTRO recently, shows that the response to immunotherapy is also driven by factors like HLA families. And we also do not understand the distribution of these factors across the world. But all of these factors are a little bit iffy because the control arm in LU005 had a really impressive median overall survival, which was 6 months longer than the control arm in Adriatic. So is it about the immunotherapy? And this is a question which we do not know, but it's a very, very interesting question to ask because in many preclinical studies, we see that radiotherapy is very, very good at killing cells and promoting tumor immunogenicity. But in other clinical studies, particularly in the melanoma space, we begin to understand that the timing of the immunotherapy response may peak very early, in some studies as early as 7 days post-initiation of immunotherapy treatment. And this is because we're not generating neoantigens, we're actually reinvigorating CD8 T cells, which have been previously primed to the cancer. We also know that low doses of radiotherapy are really good at killing lymphocytes, and above 2 gray, we've pretty much killed every lymphocyte in the field, including the ones which are presenting neoantigens to tumor within the draining lymph nodes. So we may be shooting ourselves in the foot by starting the immunotherapy too early. So in this era of immunotherapy, does dose and fractionation still matter? The answer is resoundingly yes, because in both studies, these ad hoc analyses showed that twice daily smaller fractions do better than conventional fractionation. So in summary, consolidation DERVA after chemoradiotherapy improves overall survival and PFS and should be established as the new standard of care. Concurrent immunotherapy treatment did not demonstrate a benefit. Concurrent immunotherapy and radiotherapy, particularly if the radiotherapy is to the mediastinum, may be a bad idea and reduce the efficacy of immunotherapy, and BID fractionation is superior and remains the standard of care. I'm going to move on now to discuss a very, very different group of patients and 2 randomized studies. POLSTAR, which is a randomized study performed in China, which released its interim results on PFS at World Lung, and the LAURA study, which released additional data at ESMO about CNS progression and about its Chinese patients. These are very similar studies, similar in design and similar in endpoints. Both are black box chemoradiotherapy studies. Again, similar to the Adriatic study, patients are recruited at the end of the thoracic radiotherapy. POLSTAR is a Chinese study. All the patients were from mainland China. In LAURA, patients are recruited from Asia, Europe, South America, and a very small number of patients came from the US. And again, to their credit, the authors of this study went out of their way and recruited a large number of patients from low and middle income countries. This is wonderful, but it's important to understand that lung cancer radiotherapy in Australia and other first world countries can be quite different. So in well-resourced settings, we have a very established workflow for developing lung cancer radiotherapy. And we also have the resources to deliver each step, which we know improves accuracy, improves survival, and reduces toxicity. And in Australia in particular, we are audited on every step and we receive financial incentives because our funding is impacted if we don't do things right. So if we look at the POLSTAR and the LAURA trials, their cohorts are very similar. In the Chinese patients, they tend to be younger. In the POLSTAR patients, there are perhaps slightly more patients who received sequential rather than concurrent treatment. Now, the whole basis for giving concurrent chemoradiotherapy was actually established in the RTOG 617 study. And in this trial, which showed that giving 60 gray in 30 fractions with concurrent chemoradiotherapy, we learned that the median PFS in a mixed group of patients was around 12 months, which is not that different to the Pacific study. In the mutation-driven cohort, we see a median PFS of around 11 months. It is significantly longer than the median PFS reported in both POLSTAR and LAURA. So I think, though, we have to acknowledge that both these studies do demonstrate very clearly that there is a benefit in terms of adding consolidation third-generation TKIs, and it definitely improves PFS, including a significant benefit in CNS progression reported in LAURA. Now, what do we know about the outcomes of stage 3 patients treated with chemoradiotherapy in higher resource settings? From small series in Singapore and Australia, we can see that the PFS is more than 12 months. This is very similar to data from the US, but in the real-world data from the US, where they were also able to look at the benefit of osimertinib, the osimertinib makes a big difference. It works really well, and adding a third-generation TKI significantly improves PFS. So does the radiotherapy quality matter? And is it achievable? And in brackets, what I usually hear people thinking is, but it's so expensive. It slows down trial recruitment. It's a bit of a pain, really, in a trial. And all I will say to that is that LU005 recruited 500 patients faster than expected in 3 years in more than 200 centers, and 97% of the PANs were acceptable. So RTQA is and was feasible and should be highly efficient. And is the radiotherapy quality important? We know now that adding a TKI improves PFS, but I think to really transform the care for these patients, we have to acknowledge that most of them live in lower resource settings with poor access to radiotherapy and diagnostics. And acknowledging and understanding disparity in radiotherapy outcomes is a very powerful tool for the clinicians in these countries to advocate for increased resources. In higher resource settings like Australia, we need realistic information to give to our patients about quality of life and their prognosis so that we can start having conversations about the questions that patients want answered. And we know that those questions do not just focus on survival, they also include tolerability and the kind of quality of life patients can expect to have. As a radiation oncologist, we also need to rapidly transform the way we give lung cancer radiotherapy, because we are now giving treatment which was never designed for patients who are going to live for many years. So in summary, I would say that adding adjuvant TKIs after chemoradiotherapy improves PFS in both trial and real-world settings, and both TKIs appear to be valid options. The chemoradiotherapy outcomes in the control arms in these studies do not reflect RTOG or other real-world data from higher resource settings. And this may relate to a number of factors which I haven't discussed, like access to PET staging, the use of sequential rather than concurrent treatment, or the inability to deliver a radical dose of radiotherapy. And so I would argue that to transform the care of these patients, we need to design trials which assess the entire patient treatment experience and include the radiotherapy in terms of the design of these studies. Thank you very much.
Thanks very much, Fiona, and I also have to congratulate you on being on your discussion about the Polestar study, which was in the presidential symposium at World Lung. So now, again, just a reminder to our audience that we do have some time for questions, and please enter your questions, and we'll try to address them as we can. But I might start with asking you, Fiona, a question about, I guess, the control arm of both LAURA and Polestar. So these patients who we thought had locally advanced disease had really bad outcomes. And I think you raised a question about maybe a disparity between what's seen in the real world and real world data and what was seen in the studies. But an interesting presentation at ESMO was looking at outcomes in patients on LAURA who had PET staging and patients who didn't. And the hazard ratio was just the same in both those groups, suggesting that that it wasn't just staging, that maybe the outcomes were worse even in patients who had reasonable staging. So I guess the question is, should we sort of start thinking about this as a systemic disease, even in locally advanced, in what we think is locally advanced, or do we need to work harder with staging, or both?
I think we both need to work harder with answering the question, because there are issues. I mean, I saw that presentation as well, and essentially 50 to 55% of patients in both studies had PET staging. one of the issues which came out in the Polestar study is that you could have the PET anytime up to 6 months before radiotherapy began. And we know that 30% of patients progress within the first 6 weeks of the PET. So we don't have that information from Laura. From Laura, as of yet, we do not have the information about the patients who did not receive a radical dose of radiotherapy, which is around a quarter of the patients in the Polestar study. And we also, the use of sequential versus concurrent radiotherapy is much higher. In Australia, we would anticipate around 5% of patients or less get sequential chemoradiotherapy. It's not an optimal approach. So I think these studies, I think they really do show a significant benefit for maintenance TKIs. I still feel like there are unanswered questions, and I don't think presenting hazard ratios alone about one factor when there's about 4 or 5 factors which could have impacted on survival in that cohort, it necessarily answers that question. On the other hand, I don't think there's any argument that the adjuvant TKIs are beneficial and should be considered. I just think that the solution for us is probably a little bit more nuanced than it first appears from the trial data. And the way to answer that really is to have better quality data. I mean, one of the problems is radiation oncologists didn't engage in the story until quite recently. So we do not have high quality data on our own outcomes, which we do really need to collect as quickly as possible.
Thanks, Fiona. So Lucy, the Harmony study was a presidential presentation, and on the face of it, really striking data, has a ratio of 0.5 against what we think is really the cornerstone of our first-line treatment, which is first-line Pembro. What do you think? So, what do you think it'll take to really convince us that we should change our first-line therapy strategy? You mentioned that this was a China-only study, and that there are studies that are ongoing around the world. But also, I guess we have just heard PFS data. We're yet to hear overall survival data. What do you think it'll take for us to be convinced that this strategy of bispecific targeting PD-1 and VEGF is the way to go?
Thanks, Ben. I think it's just going to take more time for the OS data to come out. I guess in that 1 to 49% population, it's really tricky to know whether this combination is going to be better than the IO chemo that we're much more comfortable using. So I think in that population, I would want a direct comparison before I would swap over. But that being said, if you look at the PFS curves between Harmony and Keynote 189, they're actually very similar, but I think we just need more time for the data to play out. The issue about the generalizability, because this was a Chinese study, I'm not sure how much that sticks. I think people just want to do a bigger study. The presenter sort of mentioned in the question time that if you look back at the ethnicities in studies like Keynote 42 and Keynote 189, there were Asian patients included in those studies. So not necessarily sure whether or not that is going to play a significant role. But yeah, I just think that 1 to 49%, maybe they do need some chemotherapy. We just don't know.
And I might ask, so Ken, a follow-up question on this. You've sort of been thinking a lot about IO combinations, and in the past, when we've given bevacizumab towards IO together with a PD-1 or a PD-L1, the results haven't really been that stunning. So do you think there's something different about this bispecific way of targeting both VEGF and PD-1?
Yeah, again, Ben, I think we need data. Bispecifics in general look like they've got more activity than you would expect to see. There's obviously the the AstraZeneca PD-1 CTLA-4 bispecific looking like it's a bit less toxic and a bit more active than the IO combination. So I just think it just looks interesting, and you wonder what is there some other effect of the bispecifics that we're not seeing yet, that we don't understand yet, that makes them a bit more active. So I am encouraged. I mean, the amivantamab is another example where we've got a bispecific, and you might not have thought it would do much better, but it did. So I think, yeah, there's something in this story, and I think we got a bit to learn yet. I want to just come back to Lucy's point, though, is I think that I agree that 1 to 49%, ideally would be to have chemo immunotherapy, but there is a cohort of patients that we all treat who we just give single agent to maybe the little, so there may be comorbidities, age, etc., where we might just use single agent. So I'd be encouraged by the data. I think, as Lucy probably is, that this looks like an exciting agent coming forward. The overall survival is absolutely critical, Ben, because there's a constant story of combination with VEGF target therapies that good PFS doesn't translate into survival. So I think that's crucial. So we have to wait and see those data come through. But I'm quietly confident.
Yeah, no, I think that'll be really important to see come through. So I think we probably have just time for one or two more questions. So Fiona, there was a question about your thoughts about PCI in limited stage small cell. And the question was that there was, the question was whether there was better outcome in patients receiving PCI in LU005 as well as Adriatic.
And the answer to that in this sort of unplanned analysis, there is, but PCI was not mandated in either study. Around half of patients got PCI, and there is an association between the delivery of twice daily radiotherapy and PCI in the studies as well. So it's not clear what's driving the potential survival advantage, because maybe those patients were fitter and more likely to get PCI. So I think that question in this setting probably isn't being answered by these studies.
I agree.
There was also, good point. There's another question about, I guess, about sort of access to radiotherapy in different in underserved populations. So with the advent of screening, which we're going to see very shortly, there'll be more and more early stage lung cancers diagnosed. And how do we make sure that patients in regional centers and populations such as Aboriginal and Torres Strait Islanders get access to radiotherapy?
I think this is a complex question. I actually think Australia is starting to do much better than it used to. We still have issues in terms of regional access. And I think as a radiation oncologist, to be frank, I'm at the end of the food chain, and I feel more pain is going to hit our radiologists and lung cancer respiratory physicians trying to prove these are all lung cancers first. And so I think the short answer is screening is going to massively impact on all of us and our resources. And we're going to have to think very seriously about how we're going to deal with the tsunami of early stage patients that we have to treat, and think about how and when we treat these patients.
Thanks, Fiona, and thank you to all our presenters, Lucy, Fiona, and Ken, for really a very excellent summary of a deluge of data. And it's now my pleasure to hand over to Dr. Vanessa Chin, who'll lead the second part of this evening's presentation. Vanessa?
Thanks, Ben. Hi, everyone. My name's Vanessa, and it is my pleasure to chair our microsatellite symposium, where we'll be discussing emerging therapies for non-small cell lung cancer with HER2 activating mutations and look at some of the different therapeutic options. So, that's me. So we've got some really wonderful speakers tonight whom you will all know. We have Professor Wendy Cooper, Associate Professor Tim Clay, and Professor Nick Pavlakis. And we are going to be discussing a number of different topics tonight. We'd like to acknowledge Boehringer Ingelheim's support, who has sponsored this session. So this is what we'll be talking about tonight. Wendy's going to be talking to us about the detection of HER2 mutant lung cancer. Tim's going to be taking us through the ADCs, and then Nick will be taking us through the TKIs. We'll be able to do a panel discussion, so please send through your questions, and I'll mediate those towards the end. First off, we'd just like to do a poll, and we'll be administering the same poll before and after the session. So you'll get about 30 seconds to answer this question. What is the incidence rate for HER2 mutation in non-small cell lung cancer? Is it less than 0.5%? Is it 3 to 5%? Is it 10 to 15%? Or is it 22%? You should be able to answer the poll now. And hopefully by the end of the session, we will all know the answer to this. Okay, so I think that poll's closed. Let's go to the next question. So the next question is, what is the most common type of HER2 mutation in non-small cell lung cancer? Is it an exon 20 insertion? Is it an exon 14 skipping mutation? Or is it low-level amplification? You should be able to answer that question now. And I know that Wendy's going to be teaching us a lot about the different types of molecular profiles that we need to get better at understanding as we are all requesting molecular testing in our patients. Okay, I think we're closing that poll now. We'll move on to the next question. What types of genetic or genomic testing do you or does your centre carry out in non-small cell lung cancer? Do you have a multi-gene panel that may only have a number of targets on the panel? Do you have an extended multi-gene NGS panel which includes HER2? Do you do whole genome sequencing or whole exome sequencing? Do you do single gene testing? Or do you do any kind of liquid biopsy, including circulating tumor DNA or cell-free DNA? Hopefully, you've all answered that. We'll move on now. How often is the HER2 gene tested on either its own or as part of a genomic panel for non-small cell lung cancer patients at your centre? Rarely, occasionally, frequently, always. Not applicable if you don't manage patients with non-small cell lung cancer, or not sure. So hopefully you've been able to answer that one. Okay, we're moving on. If HER2 alterations are not tested for non-small cell lung cancer, what are the reasons for not testing? Is it because you're not aware of any targeted therapies? There are no reimbursed therapies available. They're not on the panel done at your centre. They're not provided by pathology labs, not covered by the MBS or other, or not applicable if your centre always tests. Okay, we're closing that one now. What is your expected overall response rate for HER2 targeted therapies in patients with advanced non-small cell lung cancer who've progressed from first-line therapy? 30%, 50%, 70%, or 90%? So it's my pleasure to introduce our first speaker, who is Wendy Cooper. She's a senior staff specialist in tissue pathology and diagnostic oncology at the Royal Prince Alfred Hospital and has extensive experience in diagnostic and molecular pathology in thoracic oncology. So thank you, Wendy.
Thanks very much, Vanessa. It's my pleasure to be speaking tonight about HER2 mutation testing, and it's not just you guys that need to get to know more about HER2 mutation testing. We as pathologists need to get to know more about it in lung cancer as well, because it's not something that we've had to worry too much about in the past. So we're all on a bit of a learning curve. To understand the testing, we need to understand the mechanism. So if we think about HER2 signaling in cells, HER2, or the proper name is ERB2. It's a receptor tyrosine kinase. It's part of the ERB family. So it's closely related to EGFR, which is also known as HER1. And it's a transmembrane protein that's got an extracellular binding component that binds its receptor. and upon binds a ligand. Upon ligand binding, it forms either usually a heterodimer with one of the other ERB family members, usually EGFR or HER3 or HER4, and that leads to activation and activation of downstream signaling pathways that lead to oncogenic processes like cell cycle progression, inhibition of apoptosis, and so on. And as you're aware, there's various drugs that have been developed targeting different parts of this signaling pathway. And there are a number of different ways that HER2 can undergo variations in different tumour types. And I guess the one that we're all familiar with is in breast cancer, where HER2 amplification is seen in about 20% of cases, and it's strongly associated with strong expression of HER2 protein by IHC, which is used to screen for it. But if we look at lung cancer up there in the top right, it's quite different. Amplifications are relatively rare, and only about 2% of cases have amplification. And again, relatively rarely, a small proportion of cases, about 1 to 3%, will have mutations. And protein expression that we can see by HER2 is much more common, particularly at low levels, but doesn't really relate at all to either amplifications or mutations. So protein expression isn't really useful to us to identify or to screen for which patients may have a mutation or even amplification. So the three main mechanisms that HER2 can be activated and lead to oncogenesis are HER2 gene mutations, activating mutations, and in lung cancer that occurs in, depending on the study you look at, about 1 to 4% of cases. HER2 can also be activated by amplification of the gene in a similar proportion of cases, but they're not overlapping, or not particularly overlapping those groups. And that's measured by having a ratio of HER2, copies of the HER2 gene, as compared to the chromosome 17, in which is located, the ratio being greater than 2. Or also you can have HER2 protein overexpression, and we can see differing levels of expression. And these are all distinct mechanisms. They all have differing clinical characteristics in the patients and differing prognosis and predictive outcomes. But the HER2 mutations, one we're really interested in today, they're more likely to occur in adenocarcinoma or adenosquamous carcinoma, so non-squamous, non-small cell, more common in never smokers, more common in females, so very similar phenotype to what we're used to for our EGFR mutations. Isn't too surprising. And there's less distinct characteristics in patients that have HER2 amplification or HER2 protein expression. They're really quite different populations. So how do we detect them as pathologists? Well, for the HER2 mutation, it can be detected by NGS platforms or PCR testing. And in routine practice, these the relevant HER2 mutations are included in most NGS panels that are in common use today. So in the Illumina TrueSight panels, in the Archer panels, in the Oncomine panels, which I think are the ones most commonly used in Australia, they do cover certainly at least the most common HER2 mutations that you'd want to be finding. So if your patients are getting referred for NGS panels within Australia, they should be having HER2 testing already being undertaken as part of that panel, and hopefully being reported as well. If they're not being reported, they're probably on the panel, and you can probably have them reported. But I would imagine that anyone that's testing them would be reporting them because they're oncogenic and have potential clinical relevance. HER2 amplification, we can test for by different methods. We can use in situ hybridization, be that fluorescent or bright field, which is the way it was traditionally done still traditionally done in breast cancer and gastric cancer. But we can also use NGS to look for copy number alterations, including amplification. So if you're already doing NGS the way we are in lung cancer and you needed to look for amplification, it would make sense to look for it on NGS as opposed to something like breast cancer where you're not already routinely doing NGS for all patients, and that's why they've gone down the pathway of using ISH testing as the routine method for detecting amplification. And of course, HER2 overexpression, which if we needed to look for it, the easiest way is through immunohistochemistry, but we could also use mRNA RT-PCR if necessary. And of course, cell-free DNA can also be used and allows detection of both HER2 mutations and amplifications if there's sufficiently high ctDNA. But you can't assess protein expression, but it's not looking that relevant at the moment in lung cancer. So let's look at the actual HER2 mutations that we can get in different cancers. So this diagram shows the different portions of the gene in a sort of pictorial representation, and that blue region there on the right is the tyrosine kinase domain. And not surprisingly, across most tumor types, most activating mutations occur in that tyrosine kinase domain, the same as we see in EGFR, and lesser numbers of mutations in different portions of the gene. So they're activating exon 20 insertions in the tyrosine kinase domain. They're the ones that make up the large bulk of mutations in HER2 in lung cancer. And what these mutations are is they're small insertions, and as I said before, they involve the kinase domain. They're in-frame insertions, so involve 3 to 12 base pairs, so multiples of 3. So each 3 is an amino acid, and the most frequent one is this 12 base pair insertion, leading to duplication of the amino acids YVMA at codon 775. So you may have seen it or heard of it as A775, G776 insertion YVMA. It doesn't exactly roll off the tongue, but I think if you just think of them as exon 20 insertions, and the insertion just happens to be a duplication of the 12 base pairs that precedes it. And they resemble genetically the EGFR exon 20 activating mutations associated with primary resistance to the early generation EGFR TKIs. Again, not surprisingly, given the similarity of these genes and proteins. This is just another diagram showing a little bit more detail about the range of different mutations that have been reported in HER2 in lung cancer. So most of them occurring in that the orange intracellular kinase domain, and the vast majority of them being that duplication or insertion at Y772. But a whole range of different ones there, not all of which are oncogenic. Some of them are variants of unknown significance, so you may get that coming up in your reports. If some of those rarer ones are found, then they're not necessarily going to be ones that will respond to treatment. But fortunately, the vast majority are that exon 20 insertion that you should be familiar with. If we look at HER2 mutations across the whole spectrum of oncogenic driver mutations that we can see in non-squamous, non-small cell lung cancer, HER2 mutations are a small slice of that pie, occurring in this study about just over 2% of cases. So similar, to ROS1 rearrangement. So you will see them. And like the other oncogenic drivers, are mutually exclusive of other drivers. They're slightly more common in Asians and Caucasian populations, but not as strong a racial difference as we've seen with EGFR. More common in females, slightly younger patients with a median age of about 60. Not related to HER2 protein expression or amplification, so they're not really useful to identify them. Patients tend to be light or never smokers. They have higher rates of brain metastases at diagnosis, and they tend to have a shorter survival in the data we've seen so far. I don't want to dwell too much on HER2 amplification because it's not the reason why we're here today, but there are, and I just want to touch on it briefly because there are some clinical trials that have looked at amplification as a potential biomarker. And we just need to bear in mind that can be a different methodology to identify these copy number alterations. And looking at it by ISH has a downside in that we need additional tissue sections to be able to do that. But having said that, it's really accurate, and we get really pretty good morphology, so we can look for heterogeneity. We can make sure we're looking at the tumor cells of interest, whereas looking for HER2 amplification by NGS, you are just looking at a homogeneous population of cells. So the tumor cells are diluted by normal cells, which are invariably within the specimen. So you may miss detecting amplification due to that dilution from normal cells within it. So it can be a little bit harder to detect amplification by NGS, but it can still be done if it's necessary. And using in situ hybridization, we don't have to do it by fluorescence. We can also do it by bright field mechanisms. It's very well established in breast cancer and gastroesophageal carcinomas. So if ever we need to do it based on clinical trial data, it's quite readily deployable within laboratories. HER2 protein expression to date is not looking to be terribly promising, not very surprising in that it's not strongly related to amplification or gene mutation. And we can see quite a bit of heterogeneity within it as well. And we haven't got well-defined cut points because we haven't needed to within lung cancer either, but that would be things that would need to get sorted out if we were going to use it as a biomarker in clinical practice. And there'd be other things that you'd need to sort out if IHC testing was to be used, things like the antibody, the methodology, the scoring method. They are quite different between breast and gastric cancer, and it would be different again for lung cancer. And just looking at what co-mutations occur with HER2 alterations, if we look at HER2 protein expression, it doesn't relate particularly to EGFR mutations or KRAS mutations or HER2 mutations for that matter. It's seen across the normal spectrum of tumours, but HER2 amplification is seen more commonly in cases that have EGFR mutations, and it's not very common in patients with KRAS mutations. And of course, it's a mechanism of acquired resistance to EGFR TKIs, so you're more likely to see it in that setting as well. So thinking about HER2 testing in clinical practice, the current status is HER2 mutations are included in most NGS panels. All the common ones that I've looked at and double checked, they're in there. And amplification is potentially also accessible with the routinely used panels. And although in the MBS wording for NGS panel testing in lung cancer, it doesn't specifically mention HER2, it doesn't mean that it can't be tested for and isn't routinely tested for. And the idea with that MBS item number was that additional genes could be added in over time without necessarily having to go back to the drawing board and get a new MBS item number there. So I don't think that should be a barrier in any way. HER2 IHC and ISH don't currently have a role, but the methodology is in place if it should ever be needed. And I think the main barriers to testing are limitations of people assessing NGS that are in place in a number of sites, just due to lack of resources and funding and so on. I guess we just have to always make sure that the NGS panels that is being used locally for your patients, make sure it does cover the genes of interest. Just have a look at that fine print. Ask for a copy of exactly what hotspots are covered if it's not routinely included. And just make sure that the genes of interest and the hotspots are being covered. And I think the facilitators to make sure that all our patients are getting tested for HER2 mutations is, one, there needs to be a clinical need, and then we can really justify it. We need standardization to ensure all patients are having it covered in their NGS panels, and funding, which I think is already in place for the NGS panel. So I think testing requirements, as always, are really led by clinical need, and so we're looking to what the clinical trial outcomes are and what's going to come into routine clinical practice for HER2. I think for HER2 mutation testing by NGS, I think we should already be there or able to get there very quickly, if not already there. If we needed to look for protein expression or amplification, we may need to do a little bit of work to get that up and running in the routine clinical setting. And we await the information coming from all of you in lung cancer oncology. So hopefully that's answered your questions that you may have about HER2 mutation testing. And hopefully you'll be able to answer all the poll questions if you couldn't before. Thanks very much for that.
Thanks, Wendy. That was wonderful talk. And we're going to roll straight through to antibody drug conjugates. So I'd like to introduce Associate Professor Tim Clay. I'm sure most of you will have seen Tim speak before. He's a medical oncologist at the St John of God Hospital in Subiaco, Western Australia. He has a keen interest in thoracic malignancies and particularly into clinical trials. So over to you, Tim.
Thank you very much for the introduction, Vanessa. I'll just come back. So there's two sort of main therapeutic pathways that we can look at targeting mutant HER2 with, and I'm talking on the antibody drug conjugates tonight. Antibody drug conjugates have been in solid organ malignancy for a long time now, but their presence in thoracic oncology has been fairly limited, but we are expecting to see this increase over the coming years. So by way of background, antibody drug conjugates are best thought of as highly targeted chemotherapy. There are four major components that are needed in order to develop an antibody drug conjugate. The first is identifying the target antigen. And so ideally you want an antigen that is highly expressed in the malignant tissue, but shows limited expression in healthy tissue. At the moment, the antibody drug conjugates that have been developed are being directed against tumour cells, but there are some ADCs in development that are being designed to target matrix proteins in the tumour microenvironment as well. The antibody needs to bind with high affinity to the tumour. In theory, you don't want the affinity to be too high because there is some theoretical concerns that if the binding is too strong, the ADC won't penetrate deeply into the tumour. Another function of the antibody is that as part of its binding, that it has enhanced internalization and has low immunogenicity, so you won't develop drug antibodies in the system. The antibody is joined to the cytotoxic agent via a linker, and there's two types of linkers, the first of which are cleavable linkers, which are usually stable in the blood, but can be cleaved early in the lysosomal process as they get into the cell, or non-cleavable linkers, which have to be broken down deeper within the cell, in theory trying to reduce off-target toxicities. And finally, the payload is a cytotoxic moiety, and usually these are agents that are too toxic for generalized systemic absorption. The cytotoxic needs to be fairly potent because the amount of ADC that actually reaches the tumor is relatively small. The antibody drug conjugate has to be able to efflux or egress from the circulation and into the tumor microenvironment. And there are several different ways in which it's thought that they work. The first of these is through an immune mechanism, through binding of the antibody to its target antigen, bringing in effector cells. The second is from cytotoxic killing, from release of the payload within the cancer cell. And the third is from bystander effects from the apoptotic cell releasing cytotoxic in the tumor microenvironment, and this going on to affect other cancerous cells nearby. In the upper right-hand side, you can see the process of endocytosis as the antibody is taken into the endosome. And you can see that the first part here is where cleavable antibody drug conjugates are likely to be released. And so you get earlier cytotoxic effect on the cell and in the bystander territory, whereas the non-cleavable linkers are not broken down until they're in the lysosome further inside the cell. So the first antibody drug conjugate that was trialed was trastuzumab emtansine. This is an antibody drug conjugate that, again, like most HER2-directed therapies, was developed for use in HER2-amplified breast cancer, where it has reasonable efficacy. It has a non-cleavable linker, so it has to be broken down deep within the cell. And the cytotoxic moiety is a microtubule inhibitor with a drug-to-antibody ratio of about 3.5 cytotoxic payloads per antibody. Its main toxicities are related to the microtubule portion of the drug and include thrombocytopenia, liver dysfunction, peripheral neuropathy, which is usually the dose-limiting toxicity, and on occasion pneumonitis. There have been 2 small studies of this agent in patients with HER2 mutant lung cancer, of which you can see that Australia participated, and Prof Pavlakis was one of the co-authors in this, and I don't know if he remembers the paper, as it was some time ago. It was only a small group of patients, so 18 patients, predominantly females, and a reasonable number of patients with a smoking history. A number of these patients had received either prior HER2 TKIs in neratinib and afatinib, which have only modest efficacy, and trastuzumab. And you can see that while there are about half of the patients having some degree of response, the number of RECIST responses was relatively low, and the time on treatment was small, with only 1 patient ongoing at 1 year, and most patients having stopped either because of lack of response or toxicity. A larger study, which was conducted out of Japan, had 22 patients, so sort of more exactly of a very similar size. And again, you can see that the response rates were very similar, at around half of the patients having some tumor reduction. But again, the duration of responses was generally relatively disappointing before the patients come off drug. So an agent that has some activity, but very, very modest, and not enough for real further development in this space. The second antibody drug conjugate, which has risen to prominence in breast cancer for its fantastic efficacy, is trastuzumab deruxtecan. And in a similar way, this has also been studied in HER2 mutant lung cancer. So unlike trastuzumab emtansine, TDXD has a cleavable linker. It has a topoisomerase inhibitor 1 payload, which is DNA damaging, a higher drug-to-antibody ratio, and its major toxicities are chemotherapy-like, and I'll go through them in another slide. In looking around, the cytotoxic moiety comes from camptothecans, which we're all very aware of, and particularly irinotecan. These were found, this agent was found in a screen of bark trees in China and Southeast Asia. Quite amusingly, in Chinese medicine, this tree is known as the tree of joy, or the happy tree. And having the joy of using irinotecan, I can't imagine many patients who actually describe this as their happy drug. So obviously the Chinese are just not using enough of it in traditional medicine. So Bob Lai, who is an alumnus of Australia and at Memorial Sloan Kettering, led the TDXD studies, or Destiny, or certainly the first study, Destiny Lung 01, a much larger study with 91 patients, with the demographics very much as Wendy has described in this patient population. The patients were heavily pre-treated, so almost all of them had platinum-based chemotherapy, very high use of immunotherapy, and then smaller numbers with docetaxel and HER2 tyrosine kinase inhibitors, with most patients progressing in their prior line of therapy as their reason for switching treatment. Again, around a third of the patients had CNS metastatic disease at baseline. This is the waterfall plot, which is much more like what we're used to seeing in an oncogene-driven cancer, much higher activity with some deep responses, regardless of the HER2 mutation and the use of prior HER2 tyrosine kinase inhibitor therapy as well. I'm just trying to flip to my next slide. So the dose in this study was 6.4 milligrams per kilogram, which was not the dose that has been taken forward and approved. But you can see in a heavily pre-treated population, a median progression-free survival of 8 months and a median overall survival of 18 months, which is fairly respectable for an agent in late-line therapy. The second study of this agent was the DESTINY-Lung02 study. This was a randomized trial that was trying to dose optimize, and the patients in this study were randomized either to 6.4 or 5.4 milligrams per kilogram, and eventually 5.4 milligrams per kilogram. That was the dose that was taken forward. And so you can see here a response rate, so a confirmed overall response rate in the region of 50%. Very high disease control rate. If the drug, the time to initial response was quite quick at 2 months. So when the drug worked, it was fairly obvious that it was working. And for those patients who were fortunate enough to respond, the duration of control was quite long at 17 months. You can see here that the median progression-free survival for the whole cohort was 9.9 months with a median survival of almost 20 months. So very similar across studies. However, TDXD has chemotherapy-like toxicities here, as you can see in the adverse event profile. So a lot of GI toxicity, so nausea. It requires pre-medication in a similar way to chemotherapy, appetite issues, vomiting, and constipation. And then hematological toxicities, particularly neutropenia and anemia, and to a lesser extent thrombocytopenia, and then fatigue. Down the bottom is perhaps the most troubling side effect that we see from trastuzumab deruxtecan, and it seems to be more prevalent in the lung population, which is pneumonitis. On the left of the graph, you can see around a 13% rate of pneumonitis at 5.4 milligrams per kilogram, mostly grade 1 and to a lesser extent grade 2, but one treatment-related fatality, so 1%. You can see that the rate of the number of patients who had the 6.4 milligram per kilogram dose was much smaller, but the absolute percentages of grade 2 and higher pneumonitis were higher, which is in part why this drug wasn't proceeded with. Management within the context of the clinical trial was quite aggressive in terms of monitoring. So the patients were on 6 weekly imaging for the first year, which is perhaps an imaging frequency that we wouldn't use in routine clinical care. For patients who had grade 1, which was radiographic only changes, they were allowed to dose hold, and they were allowed re-challenge either at the same dose or a dose reduction, depending on how long it took for the toxicity to resolve. Or if they were grade 1 for more than 18 weeks, or grade 2 or higher, they came off trial. So it was very conservative management around pneumonitis because of concerns of this toxicity. Onset was usually around the second scan at 3 months, but it could be earlier, it could be quite late. And there wasn't really anything special to managing the pneumonitis other than corticosteroids and supportive management. So in using this agent in lung cancer, it's a toxicity to be particularly aware of. On that basis, Daiichi Sankyo and AstraZeneca have proceeded forward with the DESTINY-Lung04 study, which is comparing first-line trastuzumab deruxtecan to standard of care chemoimmunotherapy. It's a worldwide study, and I have not colluded with Dr. Cork at the time of writing my slides, but Darth Vader says that you can destroy HER2 mutant lung cancer. It is your DESTINY-Lung04. And here is Nick Skywalker, who prefers the precision of a TKI. So questions to be answered in the ADC space is around efficacy and sequencing of these drugs. And I think the nice thing about this talk this evening is that we're moving to a space in HER2 mutant lung cancer where we've got more than one effective class of agent. And should we be using them in combinations? Should we either with chemotherapy or with TKIs? How do we sequence these agents once we have multiple effective agents? Is there a better way? There are at least 4 new other ADCs in development in this space. So particularly SHRA1811, which has been rationally designed to try and reduce the rate of interstitial lung disease. and then finally what patient preferences are going to be in this space. And so if we've got agents with equal activity, would a patient preference an infusional therapy where they have to come to clinic, or an oral therapy? And so with that, I'll hand back to Vanessa, the chair.
Thanks, Tim. That was great. Please remember to send through your questions so that we can talk about them during our panel discussion. And now we'll go to our final speaker, Nick Pavlakis, who probably does not require much introduction, only that he is good at all things related to lung cancer and has many notable achievements, not the least of which is that he's the current chair of the TOGA board. So thanks, Nick, for talking to us about TKIs.
Thanks, Wendy, and thanks for inviting me to be part of this forum, and thanks, Tim, for the comments that you made during the talk, and hopefully I can build on the discussion that we've had with some of the evidence. Sorry, I'll progress my slide a bit quickly there. We've heard a bit of this from Wendy and Tim. The points to emphasize here is the in-frame insertions, the exon 20 accounting for the majority of the mutations, that they are mutually exclusive with other known oncogene drivers, and that amplification and mutation are generally distinct. Drug development in the HER2 space has occurred for many years, largely through breast cancer and gastric cancer. Lung cancer has come on board more recently, as Tim has indicated. And of course, there's bladder cancer, biliary tract cancer, and colorectal cancer, other tumor types which work. The development historically has been through antibodies, such as trastuzumab in the breast cancer space. And in lung cancer, we're focusing tonight, I will, on TKIs. And of course, you've heard from Tim around the antibody drug conjugates. In terms of the TKIs, many have been developed many years ago, but not progressed further due to modest efficacy and toxicity, and I'll put a big cross against those. And I'll talk to you tonight about zongertinib and the Bay compound 2927088, but there are others in development as well, and there are combination studies going on as well, as Tim has discussed. So I'll start with the Bay compound 2927088. The data was presented at the World Lung Cancer Conference in San Diego. This is a reversible tyrosine kinase inhibitor, active against ERBB2 in clinical models and showed promising activity. It acquired breakthrough status from the US FDA and also the Chinese regulatory authorities in the last 12 months. The data presented was from this study, which is a multi-cohort study. And then looking at cohort D was presented here with that, looking at HER2 activating mutations as well as HER2 exon 20 insertions. The primary endpoint of the study was safety and PK, but also in terms of activity, response rate, and investigator assessed, as well as typical secondary endpoints, survival endpoints. And if you look at the patient demographics, of 44 patients in cohort D, a point to emphasize, there's a small percentage of former smokers, 25%. As adenocarcinoma made up the majority, but a small percentage of squamous. The Y772 insertion was the dominant one in 70%, and there was just under 20% of patients with brain metastases. This was a heavily pre-treated population, with nearly a third having received more than 3 lines of prior therapy. But the response rate was quite good, 72% overall, and you can see here in the waterfall plot, the majority of patients had some degree of tumor shrinkage, and the overall disease control rate was over 80%. The swimmer plot here demonstrates the duration of benefits. The median duration of benefit of treatment was 7 months, and about 30% of patients had treatment duration of over 12 months. The duration of response was just under 9 months, and the progression-free survival was 7.5 months. And if we look more closely at the HER2 Y772 insertion, you see that it does better prognostically. The progression-free survival was 10 months as opposed to 4 months for the other particular types of mutations. This accounts for the majority of the mutations that were in the study. They're also accounted for a proportion of patients with brain metastases, where you can also see a response rate at baseline of 62%. But toxicity was observed with this drug. Diarrhea and rash were the commonest. Diarrhea occurred, if any, grade in 86% of patients, but importantly, a quarter of patients had grade 3 or more toxicity. 7% of patients had to discontinue treatment due to the toxicity. 31% of patients had dose reduction. The next study I'll focus on is the BEAMI on Lung 1 study. That's dongertinib, the Boehringer Ingelheim compound. And this, again, an update was presented at the World Lung Cancer Congress in San Diego. One of the issues around dongertinib, its mechanism of action, is its sparing of wild-type EGFR, which is thought to reduce toxicity. And that's evident in the toxicity profile that I'll show you. And this drug also has received FDA breakthrough designation in accelerating based on the data from this study. So the BEAMI on Lung trial, again, has multiple cohorts. And the cohort 1, the pre-treated population with HER2 mutation, is the cohort that was presented here. And they also looked at 2 different dose levels, 120 and 240 milligrams, undertook a futility analysis, and then elected to proceed onwards in an expansion cohort at 120 milligrams. So there's a larger population you'll see here overall, 75 patients at the 120 milligrams, median age around 60, 70% female. Again, multiple lines of therapy as a heavily pre-treated population. And the A775 YBMA insertion was for 65%. This population had a slightly higher rate of brain metastases than the previous study I showed you with the BAKE compound. And again, just to show you that a small proportion of patients will be former or current smokers with HER2, although the majority, over 2/3, are never smokers. In terms of the activity, the overall response rate of the 120 milligram cohort shown below was 72%, 240 milligrams, 78%. Pulled together, the overall response rate was 67%. The waterfall plot demonstrates substantial shrinkage across the board and with the majority of patients. But the duration of response and progression-free survival were immature at the time of presentation due to incomplete follow-up. In terms of intracranial response, at the 2 dose levels identified there, you'll see 33 to 40% disease control rate of 74% in the 120 milligram population, and a case example on the right highlighting that sort of response. This is the area that I think that this drug stands out differently to the BAKE compound, partly because of the mechanism of action in terms of sparing wild-type EGFR. You'll see the diarrhea rate is only 43%, half of that of the BAKE compound. And in terms of, and it was predominantly grade 1 and 2, with only 1% grade 3. Dose reduction overall was only 11% required, and only 4 patients, 3%, had to discontinue for toxicity. Looking at the data together, just more for illustrative comparison, because these will be the 2 competitive drugs entering the clinical arena if their phase 3 trials are positive. You see very similar activity in terms of response rates. We don't have the overall intracranial response yet for the BAKE compound. The main difference, I think, at this stage of their clinical development is in terms of the toxicities, which is approximately half with dongertinib compared to the incidence rates reported with the BAKE compound. And this is where the evidence is moving forward. The BEAMI on Lung 2 trial is being conducted in Australia. It's a randomized trial compared with Immunotherapy, and dongertinib with a crossover allowed after progression, and it's blinded independent review of the primary endpoint. Similarly, the BAKE compound is being investigated in the SOHO 2 trial with almost identical design. In Australia at the present time, as I said, the BEAMI on Lung 2 study is being conducted. We're conducting it in North Shore. I think Prince of Wales will take it on. There's a site in Queensland, Western Australia. I think you might be doing it, Tim, and of course a study in Victoria as well. So to conclude in next steps, there's obviously promising activity with the new TKIs, dongertinib and the BAKE compound. Response rates around 70%, numerically higher than what we see with the PDXD, but not a direct comparison. In the future, we will have 3 randomized trials that will set the scene in terms of which drug goes into the clinic. So we'll have 2 TKIs and the PDXD. So we await those results in terms of deciding what's the best option for our patients. But at this stage, what stands out to me is the difference is largely in the form of slightly higher numerical response rate with the TKIs and a differential toxicity. So both these TKIs have accelerated approval. the ADCs are the alternative options available to us today. And my big question is whether we'll get access to these drugs if and when the phase 3 trials are completed from a compassionate access, and I hope we do. And next steps, I think, are combination studies. Tim alluded to this as well. I think the TKIs would lend themselves in combination with chemotherapy and quite possibly with anti-VEGF compounds. And I think that's the end of my talk. Now we'll go back to Paul.
Thank you to all our speakers. That was a really interesting session. Now, I'm going to be able to give you the results of our poll, and then we'll be able to move on. We're going to retake the poll now that we all know everything there is to know about HER2 mutated lung cancer, and then go on to our panel discussion. So please put your questions into the chat box and we can talk about them. So our first question was, what was the incidence for HER2 mutation in non-small cell lung cancer? Most of you answered B, which was between 3 and 5%. Wendy, would you agree that that's true?
Yep, sounds good.
Yep. Okay, great. Second question was, what was the most common type of HER2 mutation? Most of you answered exon 20 insertion, which I think we all now know is true. Wendy's nodding. Excellent. What types of genetic genomic testing do you do at your center? It sounds like most people are doing panel testing, with a few people doing extended panel testing, and 3% of you are doing liquid biopsies. That's cool. How often is HER2 gene tested as part of a panel at your center? Most people, so 30% said always, 19% said rarely. So given that we've got the MBS code, as Wendy was saying, it seems like you should be able to access this testing, if not at your center, at a referral center. Is that right, Wendy?
Yeah, so it sounds like there's a bit of disconnect there, because it sounds like most people said they were getting NGS panel testing, but then there was a sizable chunk saying that they're not getting HER2 testing done. So I would say they need to check in their reports whether that NGS panel includes HER2, and check that it's being reported, if it's included, if it's being reported. And if it's not, ask if the panel does cover it and they're not just not choosing not to report it because it's not known to be clinically relevant yet, so it may be available.
So that's really important to check that if they're doing it, that they're reporting it. The fifth question was, if HER2 alterations are not tested for, what are the reasons? For most of you, it was either reimbursed therapies are unavailable, which I think we can all agree is a big problem. And what is your overall expected response rate for HER2 targeted therapies? Most of you answered 55%, which, given what Nick was saying, is probably a little bit pessimistic. Is that right? We can maybe expect something a little bit better than that. Okay, so now maybe we can try and make this second poll a bit faster. Could you answer this question now we know the answer? The moderators will let me know when you've all clicked. So the faster you click, the quicker we can get on to an exciting panel discussion. Okay. What is the most common type? This should be easy. Fast draw. Click as fast as you can. What are your overall expected response rates? I have to say, it seems like you're all answering really quickly. So that's well done. Thank you. And what is the one takeaway from this symposium that would change your practice and why? So presumably this is a free text answer. I'm going to open the panel now. I might start off with a question to Nick, but Wendy may have some thoughts to add here. With the new TKI compounds, Nick, how are they new, better, different to the old TKIs? And an additional subpart question, why do they work better in the YVMA mutations versus other mutations?
It's right to the question. I actually don't know the answer to that. It might have to do with the biochemistry, I think, of the compounds in the pockets. It's a bit like the evolution of the EGFR TKI from the afatinib, which was the broader toxicity, as you recall, and erlotinib, and I'd put those first basket ones similar to that, and then osimertinib, the new generation ones we have in EGFR, higher specificity, less off-target effects, more on-target effects and better CNS penetration. So I can't tell you about the biochemistry, but I think that's broadly how they've evolved in a similar fashion to the EGFR sensitive mutation TKIs.
Wendy, is there something about that particular insertion that you think makes it more vulnerable to blockade, or?
It has to do with its molecular structure and its pocket. It is the more common one for B2, and the way the drugs have been designed, I think pharmacologically is to do with that. But I haven't looked at the detail around the biochemistry of the drug and its how it inserts into its binding pocket. But I suspect that's where the answer lies.
Yeah, and I can't really add anything to that. I suspect that's exactly as Nick was saying, and it was interesting to see that the commonest, that YVMA insertion, does seem to be the more sensitive than the non-YVMA one. So the design so far is looking good, but you always expect with newer generations that they may become more effective against a broader range of variants.
And is there any discussion around why an intracellular TKI approach seems to be more effective than an extracellular, like antibody binding approach?
My quick answer to that is I was thinking of this as the presentation was going on a little bit. If you look at the history and the evolution of the targeting against EGFR as a whole, you look at the sensitivity of the TKIs, gefitinib, erlotinib, afatinib, and Nexton, and then cetuximab, which was the antibody that we had against EGFR, which actually did show responses, but only in high expression cases. And I think, again, that reflects, I guess, the drugs of the time, the binding capacity of the time. Cetuximab didn't have a payload like the ADCs we have now, which is why we're seeing much better responses with TDXD at a cost, of course, with toxicity. But as Tim showed us, they've been developed better, to bind better in terms of their cleavage and their payloads and with the high DAR. So, but the TKIs, I think small molecules, they get in, and I think its biology is very similar to what we observed with EGFR exon 20, as well as with the sensitizing mutations and other oncogene drivers where TKI-based therapies seem to have very high sensitivity. But we don't know yet around the failure rate and the developing of resistance yet. It's a common time.
I mean, if you look across from, I mean, I think it's about mechanism of action as well. The antibodies are binding to an extracellular portion, and that affects the ability to single internally, but the mutation is already internal and overactive. So with just a naked antibody, you're probably not going to achieve much. And again, if we look across to the EGFR mutant space, EGFR antibodies aren't active there, but if you look at a bispecific like amivantamab, where you're blocking both EGFR and a bypass pathway, you're getting extra activity.
And Tim, I've not used TDXD before. I don't treat lung cancer. How do you think it's going to mix with chemo and immune therapy in the Destiny-04?
I think you don't treat breast cancer is what you meant.
I
think you
what
do
did I
treat
say?
You don't treat lung cancers. I think you might. So look, I do treat breast cancer as well, and I've been involved in the Destiny Breast 12, which was CNS disease, and it was a magic drug. In breast cancer, it's been an absolutely magic drug, but it's not quite the same disease in lung cancer. And I guess the difficulty is, what are we actually going to be combining these things with? And again, there are examples in the breast cancer space of sometimes two active agents don't go well together. So there was a study in breast cancer of combining trastuzumab emtansine with pertuzumab, which in theory should work really well, but didn't actually add anything much. And so I think if we're going to look at dual targeting of HER2, we actually have to look and go, are we getting anything extra? And so ideally, those sort of TKI and ADC combinations should be tested in cell lines and in single arm studies first, rather than just rolling out to larger studies. I think although HER2 mutations, they're not common, but they're not entirely rare, patient population here is not huge. And so we have to be very careful about how we design our studies, not to sort of devote large numbers of patients with an uncommon condition to studies that may actually be futile. So I think it should go back to basic biology first. I also don't know how much we're going to get by combining trastuzumab deruxtecan with standard cytotoxics. There are some sort of ADC and chemo combinations in lung cancer, certainly with datopotamab and chemo, but that's a sort of, again, different biology. So I think we've got to think very carefully about what we combine and have a good preclinical rationale for doing it before we do it.
Okay, and look, that takes us up to the last part. Before we say thanks, sorry, the poll, the post-education poll looks a lot better. So the incidence rate for HER2 mutation was answered correctly by 90% of you, so well done. Second question was the most common type of HER2 mutation, answered 100% correctly, so applause for everybody. And what is your overall expected response rate for HER2 targeted therapies? 73% of you said 70% and 30% of you said 50%. And I think whether you favored Tim's talk or Nick's talk, you'd be right. So I think that's about right. Takeaways from the symposium, a few of the things that you said was to ensure that testing is performed and have a check with your local provider and make sure. Looking for compassionate access, and that we need more clinical trials, which I think we'd all agree is the case. So thank you, everybody. Thank you, Wendy, Nick, and Tim, and all the previous speakers for attending. There is a feedback survey, and also, so scan that. And then I believe there's another event that we would like you to attend, 6:30 p.m. And I think that's the end. So thank you very much. And thank you to BI for sponsoring us. Good night, everyone.